Welcome, everyone. I would like to welcome everybody here at UMSL as well as Mizzou. We're live streaming from here at UMSL to Mizzou, and this is the next in our Discovery series with Next Gen Precision Health. This really represents the connectivity that we hope to build across all four universities. This is the first trial of this, and we had a little bit of a technical difficulties getting started, but hopefully everybody can hear me on the other end. So it is a great privilege to welcome our speaker that is agreed to be a test subject in this forum. So Dr. Rachel Winograd is a associate professor and a licensed clinical psychologist here at UMSL, and is going to talk to us about her work. She also directs the addiction science program within the Missouri Institute of Mental Health. So I would like to welcome her to the stage here for her talk entitled The Current State of Missouri's Overdose Crisis and Recent Mitigation Strategies. Welcome.
Liftoff. Thank you so much for having me. I'm really excited to be here and happy to be a test subject anytime. We're going to get right into it because we have a lot to cover. I'm going to start by talking about the landscape of an overdose crisis to ground us in where we're at, give some background on opioid use disorder and treatment and harm reduction efforts, as well as the role of stimulants like methamphetamine and cocaine in our overdose crisis. We're going to do a deeper dive into the racial disparities that we see in treatment access and overdose deaths in our state, and then look ahead to what comes next. Before we get into any of that, I want to do a little exercise with all of you. I know some of you are eating, but humor me. Get out a pen and paper or your phone. The Notes app will work just fine. I'll pause for a moment while you do that. No exceptions. I don't care if you're a vice provost or chancellor. Oh, you didn't bring your phone? Oh, how respectful of you, actually. Okay, well, do it in your head. Okay, at the top of your paper, I want you to write down your drug of choice. Okay, keep it to yourself. Okay, right, this could be alcohol. Remember, caffeine is a drug. Nicotine is a drug. We can talk about opioids. We can talk about stimulants. You don't have to tell anybody. Write it at the top. Sugar, rich foods, whatever brings you pleasure. You know what I'm saying. Then below that, I want you to write all the positive things you get out of that drug. What does it do for you? How does it make you feel? No right or wrong answers, whatever comes to mind, as much as you can think of. Okay, now I want you to go back to the top of that list and cross out your drug of choice or delete it, and instead write, I need. Then I want you to look back down at your list. We do this as a reminder that people use drugs for reasons. Human beings have always used drugs. We will always use drugs. It's actually not even limited to human beings. Many mammals do too. Dolphins, goats. Okay, the point is we use drugs for reasons. They fill needs in our lives, in our cells. And it helps with our understanding of shame and stigma and judgment for people who use drugs. And we say, why don't they just stop? Why don't they just use their willpower? Well, what's going to take its place? If we tell someone clinically that they need to reduce or quit their drug use, that means they're not going to get an essential need met. What is our recommend? How are we going to work with them to get those needs met in other ways? So let's just keep that in mind as we go through our talk today, that drug use is really complicated. Addiction is really complicated and rooted in a lot of core issues and needs that we don't have other easy ways of addressing in our society. Okay, let's talk about the overdose crisis. Let's just go straight into talking about death, preventable death, because that's what this is. We know that we've been in an overdose crisis for the last couple of decades at least. 25 years or so at this point, and we know we saw a big uptick during the COVID years. We just got new national data a couple weeks ago about preliminary 2022 numbers where we continued to see an increase, though it was small, a 2% increase nationally. And there's a lot of variability across states in terms of these numbers. We saw a similar pattern here in Missouri. We saw a big uptick during COVID and we're starting to plateau, but the same, about a 2% increase in 2022. Now, we see hopeful signs that maybe this is plateauing, maybe this is starting to go back down. But as we'll talk about today, we have a lot of emerging drug threats that make this really complex and difficult to address. Here in Missouri, what are we looking at? Let's look at the change from 2021 to 2022. And you'll see actually that across the regions in our state, every region, for the most part, either stayed level or even saw a decrease in deaths, but it was the Kansas City metro area last year that saw an increase that pulled the statewide increase up. What about who is dying? If we disaggregate by gender and race, it's a pretty clear story here. Granted, we only have this state level data through 2021, and I'm curious to see what our 2022 numbers will look like when broken down by race and sex. But you'll see that Black men in Missouri are disproportionately affected by overdose, clearly. Not even a question. There is one line that is not like the others, and that's among Black men, and we'll get to that later in this talk. What are people dying of? Increasingly, it's this steep gray line right here, and that's fentanyl. Fentanyl is a synthetic opioid. It's much more powerful than heroin or morphine, and at this point, it's entirely taken over our opioid drug supply. You cannot find heroin in St. Louis, and you'd be hard-pressed to find heroin elsewhere in the state. Every opioid has fentanyl in it, and increasingly other drugs have fentanyl in it as well, including stimulants like cocaine and methamphetamine, and also benzodiazepines or pressed pills that people might get online. The reason this is scary is because, like we've already covered, a lot of people use drugs. And when we don't know what's in them, there's an inherent level of risk and Russian roulette, really, that we play anytime we buy a drug on an unregulated market. What I will say, and we're not going to go into the weeds of this in today's talk, but it is tricky to talk about fentanyl and the very real threat that it brings when you ingest it, while not getting into moral panic mode and going into myth territory. So just for the record, I'll remind us all that you cannot overdose from touching fentanyl. You cannot overdose from just being in the same room as it or breathing it in. And this is real because we see these news stories all the time among emergency responders. So one thing that our team does is do real hands-on training with first responders and other community partners about what to believe and what not to believe about fentanyl. Okay, why do people use opioids? Pain relief, euphoria, sure. When does it turn into substance use disorder or addiction? This is a really helpful figure that I've used for the last many years because I think it really cuts to the chase. You develop a tolerance to opioids really quickly. So at the beginning, for some people, it might take you from normal into euphoria, from the white zone into the green zone, make you feel warm, fuzzy, tingly. Some people say it feels like being wrapped in God's blanket. You know, we've heard all sorts of ways that opioids make people feel really, really good. But then quickly, you start to either need more or what you're using doesn't have the same effect, and that's tolerance and dependence. And so really, you just start using almost just to get back to baseline, to feel normal. And when you're not using, then your body goes into withdrawal. And that's just like the absence of this opioid in your system, and that's the red zone. And that's scary because being quote unquote dope sick is incredibly unpleasant and uncomfortable, and those are like euphemisms, those are understatements. When people go into opioid withdrawal, we're talking full body aches and pains, diarrhea, vomiting, chills, crippling anxiety, insomnia, vomiting. Did I say that already? It's one of the most horrendous human experiences that people describe, and they will go to great lengths to avoid it. So this is when it gets particularly scary and dangerous, because when you are in that type of survival mode, you will do a lot of things to get your next dose that you might not otherwise do. Luckily, we have medications for opioid use disorder. There are 3 medications that I'm going to quickly review here. These are the only 3 that are FDA approved to treat opioid dependence or opioid use disorder. So the first one is methadone. FDA approved in 1972. It's a full opioid agonist. You can think of it like a brightly lit light bulb fitting right into an opioid receptor socket. So it satisfies people's cravings, alleviates withdrawal, and gives people that opioid that they might need in their system. Because it's a full opioid agonist, though, it does come with risk, meaning you can overdose from it if you take too much. In our country, we are only able to get methadone for opioid use disorder from a specific type of place. They're called opioid treatment programs. There are 13 in Missouri. Good luck getting into one. It's very, very difficult. You have to go 6 days a week for the first 3 months in tons of barriers and hurdles. But to this day, it's still the most effective molecule, the most effective medication that we have in terms of reducing opioid morbidity and mortality. Next, we have buprenorphine. This was FDA approved 30 years later in 2002. You can think of it like methadone light. It's a partial opioid agonist. It sits in these receptors like a dimly lit light bulb, so nothing else can get in, and it kind of gives you a little bit of a opioid feeling, so there's some substitution effect. But because it's only a partial agonist, there's a ceiling effect, meaning you can't really overdose on it if you just take buprenorphine alone. Because of that and those properties, it can be much more flexibly prescribed, primary care clinics, other addiction treatment clinics, hospitals, mobile units. We can give out buprenorphine a lot more readily than we can methadone, and it's almost as effective. Then there's naltrexone. This works differently. This is an antagonist, meaning it's like a dead light bulb that just sits in your receptors so nothing else can get in. It blocks the effects of other opioids, so if you try to use on top of it, it doesn't work. This has not been shown to reduce overdose specifically, but it can help prevent relapse. Psychologically, if we know that using won't do anything for us, this can be effective. But really for a subset of populations, but this is another tool in our toolbox for sure. So coming back to this green, white, and red graph, when we think about these medications, specifically methadone and buprenorphine, what they do is help people level out in the white. You take them once a day instead of what we need with fentanyl, which is a short half-life, and maybe people are injecting 8 to 12 times a day and chasing it all day long. You can take it once a day and it keeps you stable, and you can go about your life and address your priorities, whatever those may be for you. So these medications are incredibly effective. They're shown to reduce overdose rates by 50 to 80%, and yet they're still incredibly hard to get. So let's talk about how we have approached OUD treatment in Missouri historically. So when I came on the scene in late 2016, late 2017, and was privileged enough to work so closely with our state agencies and SAMHSA and other program funders and developers to come up with a new way to address our state's overdose crisis, we said, well, let's look at how we've addressed it historically. And this is a pretty traditional model. One is a big reliance on detox. Detox is kind of a dirty word, honestly. A colleague calls it the rinse and spin. All it is you go in somewhere for a few days, you get drugs out of your body, but then what? Then you're back out with no tolerance in a deadly fentanyl market? Good luck. So detox alone is not treatment. Let's remember that. We have an over-reliance on residential and group therapy. Sometimes residential treatment is needed, but not most of the time. And also, we don't need to be churning people through groups, 6, 8 groups a day. I used to run groups. It's really awkward. People don't want to be there. They're not super effective, but you mandate them to sit in those seats because that is the sort of the paternalistic model of treatment often, and that's how these systems were built. We also have viewed it through an acute care lens rather than a chronic care lens, thinking that you can, quote unquote, complete treatment or go to rehab and be cured. Addiction, again, it's more complicated than that. It doesn't work like that. It's not a course of antibiotics. And if we did use buprenorphine and methadone, it was only as a last resort, kind of once you've, quote unquote, failed other things, and only at low doses or for a short amount of time. I met a psychiatrist early in 2017 who said he only gave buprenorphine for 6 months max, because that was his rule. There was a local clinic who said, yeah, we'll do buprenorphine, but we only do it for 3 weeks, and then they have to get on naltrexone. So you see there are all these sort of arbitrary limits. And we had to say, those are not working. In fact, in a lot of cases, those are increasing people's overdose risk. So what if we actually borrowed from a comparable model, the housing first model to chronic homelessness, where the idea there is you prioritize rapid and sustained access to a life-saving resource. For people who are unhoused, that's housing. For people with opioid use disorder, that could be medication. So we developed the medication first approach to OUD treatment with 4 key principles. The first being about chronology. Get people access to medications as quickly as possible. The second, no arbitrary tapering or time limits. If it's working for people, let them stay on it. The third, this is a tricky one, counseling should be offered but not required. And this ruffled a lot of feathers in these traditionally counseling-based programs, as you can imagine. And fourth, do not discontinue medical treatment unless the medicine is what's worsening a patient's condition. So this comes into play if people are continuing to use other drugs. For example, do we cut them off their meds? No, we do something else to address those other drugs. So I'm zipping through this because we have a lot of stuff that we've done since then. But in the first year and a half of the medication first model, disseminated throughout Missouri's publicly funded substance use treatment system, of which there were at that time over 26 sites or 26 agencies and 60 sites across the state, thousands of people treated through Medication First. We compared them to people who were treated at those same agencies the year prior, before Medication First was even developed. And indeed, people enrolled in Med First programs were more likely to get medication, more likely to get it sooner, receive fewer psychosocial services because they became optional, still be engaged in treatment at every time point we measured, and cost the state 21% less per patient per month. So we published on this in 2019. We're like, Med First model, this is going great, this is the future. And we've just recently released our 5-year report. How is Medication First 5 years in? Now, some text is small here. I'm not going to go through every nook and cranny of this slide, but I do want you to look at this bottom panel here. The light yellow means no medication. So you can see in the first year of STR, the State Targeted Response Grant that I'm talking about, 89% of people got medication. That's a lot. That's pretty good. That's way better than the first year in the top left, which was 43. But if you look over time, you see the yellow gets a little bit bigger, meaning medication rates are getting a little bit smaller. And you look at the panel above, and this is now we're comparing to other programs, or the same treatment agencies in Missouri, but enrolling people not through the Med First path. Medication rates there have gone actually up a little bit. So we're seeing this gap close. But essentially, the upshot of this slide is we have plateaued. We made a lot of progress coming out of the gate strong with Medication First early on, and we're not really seeing movement past that. If anything, there's a little bit of regression back to baseline. When we have time to really get in the details of what's happening clinically and programmatically, I like to talk about the different levels of barriers for why this is happening. At the patient level, at the clinician level, talk about biases or stigma. At the agency level, talking about different clinical workflows or who has medical staff. And then at the system level, what types of reimbursements are we offering? What types of financial incentives? What types of billing? Some of this like not very glamorous infrastructure stuff on the back end that really drives clinical practice. Okay, so let's transition from treatment, which we think of as very clinical, people still enroll in it, you gotta go to your appointments, to a concept called harm reduction, which is more of a philosophy or a framework about how we work with people who engage in risky health behaviors. And for the most part, we're talking about drugs and sex. So harm reduction could be everything from distributing condoms or PrEP to prevent HIV. Harm reduction could be wearing your seatbelt, though, in a car to decrease your danger if you get into a car accident. Or is anybody holding one of those Bic pens with a little hole in the cap? Let's pretend you are. Someone say yes. Oh, you are? What do you think that hole is for? A+. To stop babies from choking, because we're not encouraging babies to swallow pen caps, but we know they will. So if they do, that doesn't mean they deserve to choke and die. So we have a little hole in the top so their air can get through. That's harm reduction. Coffee sleeves so you don't burn your hand. The idea that we're gonna do things anyway, how do we make those things more safe? And that can apply to drug use as well. Specifically, we do a lot with naloxone. Naloxone is the opioid overdose reversal medication. You can see pictures here in the bottom right. You can spray it up your nose in a nasal spray. Well, you can't spray it up your nose because you're in an overdose state. Someone else will spray it up your nose. Or we also distribute a syringe and vial that can be injected into anyone's big muscle. It pulls you back from an overdose and saves your life. That's the only thing naloxone is good for. It doesn't do anything else. But that's pretty miraculous, if you ask me. There's some quotes that really drive our work on the addiction science team from a harm reduction perspective. One is from a leader in the field, Dr. Jessie Gaeta. I saw her present years ago, and she said, "You don't have to stop using for me to start helping." And that was written on a chalkboard outside her clinic. And she said she lived by that motto every day, because that's really different from how a lot of people approach treatment and how a lot of people have been socialized to think about treatment and recovery, which is you have to hit rock bottom. You have to quit everything. You have to show me that you're ready for treatment. And we said in this world, like we can't afford that anymore. With this drug supply, with fentanyl out in the streets, that's a death sentence. So here, let me help you stay safe and alive with dignity while we do what we can to move you in whatever direction you want to go. Another leader in the harm reduction field is Dan Bigg, who sadly lost his life a few years ago from the Chicago area. And his quote was, "Any positive change." This idea being it doesn't have to be all or nothing. It doesn't have to be abstinence only. Any movement toward positive change, we can celebrate that and consider that a success. And that's really up to you. Our team's been criticized as relying too much on harm reduction. A few years ago, there was a letter to the editor in the Post-Dispatch that said that the work we do here with our naloxone distribution is equivalent to throwing a life preserver to someone drowning in the ocean. And I said, heck yeah, absolutely. We're not then driving the boat away and leaving them to drown. Like, what's the implication there? I will stand by that with pride any day. Yes, naloxone is a life preserver to someone drowning in the ocean. It is not the panacea. It is not everything. But people need to have a second chance, a third chance, a fourth, a 10th, a 20th chance to live another day. Who knows what's going to happen? And that's our duty as fellow human beings. So we have distributed a crap ton of naloxone in the last 5 or 6 years. So shout out to our community harm reduction, first responder harm reduction team, some of whom are here today. The rest, I saw chats, are unloading pallet jacks and meeting at the dock. It's like a real industrial operation here. You can see some maps here if you go to getmonaloxone.com. You can see some metrics where we show how much naloxone we've distributed by county across the state, also by different sectors. So you'll see we give the most naloxone to street outreach and harm reduction groups, and then on up with treatment providers, law enforcement, housing, health departments, EMS, et cetera. To date, we've distributed over 170,000 naloxone kits across the state of Missouri, and almost half of that has been in just the last year alone. And this is not without effort and blood and sweat and tears, and all three of those, literally, pretty sure. Hope there are no workers' comp attorneys listening. I'm sure everything's fine. Anyway, here are just some snapshots from our storage rooms. Thank you, Dr. Spilling, for, we might need another storage room soon. But you can see this is like real labor and effort. These naloxone kits get packed and shipped out into the hands of people who use drugs, their family members, their associates. We work with pawn shops and liquor stores and barber shops, lawyers' offices, whoever around the state, big hospital systems, one-person operations who do street outreach in a corner of Missouri that we've never been to. The idea is getting naloxone out far and wide, and we are privileged to have been able to do so with the support of the Missouri Department of Mental Health and Department of Health and Senior Services, who have to their credit, made naloxone a statewide priority with their opioid mitigation funding. If you want naloxone, I'll have the website on the last slide, but we've developed a pretty good infrastructure now. If I do say so myself, I can say that because I had nothing to do with it. But our team has just really taken this and run with it, establishing a one-stop shop for anyone in Missouri. GetMoNaloxone.com, and you can fill out your information. If you're an individual, we work with a mail-based operation who will mail it straight to your door, no questions asked. If you're a massive police department, we'll train you up and give you naloxone, and everyone in between. Where does naloxone fit in on this broader harm reduction spectrum? We talked about harm reduction as a philosophy, but materially and in terms of methods, there are all sorts of strategies that represent drug-related harm reduction. What we're doing right now that we're pretty excited about too is developing some scales to measure how people feel about each of these initiatives or each of these types of strategies that you see on the screen, because they may indeed sort of fall along a continuum where some people might say, okay, naloxone, sure, that makes sense, especially for first responders. I'm not going to let someone die in front of me, but maybe I don't want you giving naloxone to a bunch of active drug users, because isn't that going to be enabling? Isn't that going to encourage them to keep using drugs? Well, what a needle exchange, don't get me started. Giving needles to people to inject drugs, that's really just condoning it. Or people might say, no, I'm good with all these things, but I might stop short at, let's say, safe consumption spaces. What we see in Europe and Canada and now have been legalized in New York City and recently Minnesota as the surprise second state in our country. But safe consumption spaces are exactly what they sound like. Sterile environments with medical staff and peers on board. You bring your own drugs. You have sterile syringes here. There's naloxone on site. You use drugs here so that if you overdose, you won't die alone. And this is a really controversial effort, as you can imagine. So we're not anywhere close to that in Missouri. But what our team does and takes pride in is trying to move us conceptually, at least attitudinally, along the continuum to say, hey, if we view people who use drugs as full human beings, just like all of us here, then how can we keep people safe and healthy and alive, acknowledging that the harms from the drugs themselves are a part of it, but often the bigger harms come from the systems and the environments around them, come from sharing dirty needles, come from using by yourself, come from getting evicted from public housing because you had drugs in your pocket, come from getting locked up in jail for 72-hour holds multiple times a year and coming out with no tolerance and no job. These societal impacts of drug criminalization and prohibition are a big part of the harm reduction movement as well. So it's not just these strategies and these methods, but it's also a movement. What we've done to get this message out is a ton of training. We've also done public service announcements and coalition building and one-on-one meetings, but many of our grants focus on formal trainings for departments, for agencies, for community coalitions. And to date, I got updated numbers this morning, we've trained over 35,000 people across Missouri on harm reduction principles and strategies, not just naloxone, but going beyond that. What does addiction mean to you? How can we help? What are evidence-based treatments? And we have been effective at increasing knowledge about core topics like naloxone access and syringe access. We do this through surveying our attendees as they are starting the training through a pretest, surveying them immediately following the training and seeing how their knowledge and attitudes have changed. We've also improved attitudes around naloxone access and people who use drugs in the first place. People carry a lot of stigma toward drug users and toward medications for opiate use disorder, which is now coined intervention stigma. Distinct from the stigma we hold toward people, we also hold stigma toward actual interventions or medical procedures. And we've also developed the state's only centralized tracking system for non-fatal overdose events. You'll notice at the top, I talked about overdose deaths and stats and where we're at in 2023, but we have not yet had a way of capturing what about all the overdoses that are reversed, where people survive. And so in 2017, we developed our Overdose Field Report, or our ODFR. And we've logged over 12,000 reversals. Not necessarily all through our naloxone, but probably a lot of them. People anonymously report when they've survived an overdose or they've responded to one or saved a life. So we're able to see the characteristics associated with those overdose events and use those also to get a sense of what's happening across the state and where we need more efforts. Here's some snapshots of some of our training environments, so you're not just taking my word for it with the bullet points, but we are out and about all corners of Missouri. So where do stimulants fit in? Thus far, I've really focused only on opioids, which indeed drive over 75% of overdose deaths in the state and nationally, but we're seeing more deaths related to stimulants, specifically methamphetamine and cocaine in the last few years. People refer to this as the fourth wave of the overdose crisis. The first starting with prescription pills, prescription opioids in the 90s, transitioning to heroin in the aughts, then to fentanyl in the 20-teens, and now here we are with more of a polydrug or stimulant-involved crisis. Here in Missouri, indeed, we saw like a 1.8% increase in opioid deaths in 2022. So like I said, starting to level off, but we're continuing to see increases in stimulant-involved deaths with 8.2% of the 8.2% increase highlighted here in the middle is a combination of opioids and stimulants. So this means it's not just people like over-amping on a stimulant or having a cardiac arrest from taking too many stimulants, but when you look in their toxicology reports post-mortem, there were both opioids like fentanyl or heroin or morphine on board, but also stimulants like cocaine or methamphetamine or amphetamine. Indeed, in St. Louis City and County last year, if you look at this bottom right corner that says 31%, last year was the first year in our recorded history that we've gotten data on this where the largest chunk of deaths was from opioids and stimulants combined. So why is this happening? It's helpful to think in terms of different buckets, if you're like me. So first of all, let's be real here that fentanyl is the driver of most of these combination deaths. It's not, I know I said heroin and morphine earlier, but I'm just trying to give equal opportunity. It really is fentanyl in over 90% of these deaths. It's helpful to think about it in two main buckets. One is intentional co-use and one is unintentional. So intentional co-use is when, for example, people are sitting using both types of drugs simultaneously in a single episode. So this could be using heroin and cocaine, which is referred to as a speedball, or methamphetamine and fentanyl, which is now called a goofball. But the idea is you're using them together because they bring different effects. The second possibility is concurrent or recent use. So maybe I'm using fentanyl during the day, but then I use methamphetamine to stay up all night. We heard about a big increase in this in early COVID days with rounds of evictions, when many more people were sleeping on the streets, left unhoused. They hadn't historically had a stimulant habit, but now in the phase where they had all their stuff and they had to protect their stuff and their safety, they use methamphetamine to stay up all night to guard their own safety and security. So this is another way that like our environments influence our drug use patterns. The other category is unintentional consumption. So this is, you might think of like, when things get quote unquote laced with fentanyl. So this could be unintentional, where you're looking somewhere along the supply chain of drug use and drug trafficking. And let's be honest, it's not necessarily always the most precise, the most sterile, the cleanest, Breaking Bad type laboratories. We're talking about messy kitchen tables. We're talking about wood panels where people might mix drugs on a wooden table. A little fentanyl gets in the nooks and crannies of the table. You don't fully pressure wash it, but then you mix cocaine on top of it, and the tiny little bit of fentanyl gets into the cocaine baggies. You sell that on the street. You sell that to people who just think they're getting cocaine for some party or some rave, and they are not used to having opioids and have no tolerance for it. That little tiny trace amount of fentanyl can absolutely kill them. And we've heard that. Mass overdose events in St. Louis. We heard this at the Parkview Apartments in 2021. We lost 9 people in a 36-hour span thinking they were getting crack cocaine, and it had fentanyl in it. The second possibility is that the supply was laced on purpose. This is a malicious angle. It's not giving the benefit of the doubt to people who use or sell drugs. And we don't have a lot of evidence that this exists on any mass scale, but we've heard enough anecdote that it warrants a spot on a slide. The idea here is, why would a drug seller purposely contaminate their own supply and risk killing their customer base? Doesn't make sense economically, but perhaps it happens from time to time, but not nearly as often as it's portrayed in the media narrative. Regardless of the reason, we can take some of the same lessons out of it, which one is that drug checking is important. And when I say drug checking, I mean knowing what's in your drugs, knowing what you're putting in your body. And the second is that people who use stimulants or really use any drug on the illicit market, they should have naloxone too. If you're buying drugs from anywhere other than a pharmacy or a hospital or doctor's office, it's possible that fentanyl's in there. The exception here, don't believe the myths and the hype about fentanyl-laced marijuana. We have no evidence for that, of like the cannabis flower, marijuana. That, it doesn't work like that. You can't sprinkle fentanyl on that, it would burn off. But everything else I said, if you use drugs from the illicit market, you should have naloxone on you. And now after this talk, you'll all know where to get it. Okay, back to drug checking, this idea that people should have a right to know what they're putting in their body. When we live in the country that we do, where our drug supply is as unpredictable and volatile as it is, this is the next era of harm reduction, is drug checking. Ideally, we'd be able to use mass spectrometers and real sophisticated chemistry equipment to test each supply and do it rapidly on street corners. And some cities and counties and states are starting to develop that. And that's what's on the horizon here. We need to legalize it first in Missouri, but we'll cross that bridge. But what we can do in the meantime is distribute fentanyl test strips. So our team has distributed over 360,000 in the last couple of years since we were first granted permission to do so by SAMHSA, the big federal agency who's really in charge of us. Fentanyl test strips, again, they're not the be-all, end-all, especially for people who use opioids, because like everything has fentanyl in it, so they're kind of pointless. But we distribute fentanyl test strips targeting people who use stimulants for the most part and are opioid naive, because this is where they can have the most benefit. The idea is you can test either your drugs or test your drugs before you use them. That's ideal, but has historically been an illegal gray area. Or you can test your urine after you use, if you're still alive. But the idea is this is a harm reduction tool that is just another tool in our toolbox to help people get more aware of what they're putting in their bodies. You can see it's not without more manual labor and effort. When we signed up to distribute fentanyl test strips a year or two ago, we got in a little bit over our heads. I think that was my fault, but we didn't realize how much time it was going to take to pack them. You'll see here some of our packing parties, as well as some of us may or may not have enlisted our children for small allowances to pack fentanyl test strips. My, at the time, 8-year-old did a pretty good job for 5 cents a kit. My younger ones in the top left were not very good. And we have quickly moved on to different strategies to pack those kits. Thank you very much to our team. And also now we host community packing parties every Wednesday, which has been a source of enjoyment and partnership. If you look at where we've distributed these fentanyl test strips around the state, we've tried to target each region as much as we could, not make it so St. Louis heavy as we have a lot of our opioid efforts, because St. Louis is really the epicenter of our opioid overdose deaths. But you'll see we've got a bit of an equal distribution statewide. And what we just did as well is try to survey a lot of the staff and service workers at these treatment, harm reduction, recovery organizations who receive these fentanyl test strips that we give out. You know, there's a decent amount of research out there about people who use drugs and what they think of fentanyl test strips and how they use them. But this is a really new intervention, especially for states like Missouri, where we don't have a long history of harm reduction friendly policies and infrastructure. And so we got nearly 100 respondents, and we heard across the board that their top motivator for distributing fentanyl test strips to their participants was their concern about fentanyl in the stimulant supply. So this reinforces our initial motivation for giving out FTS and also knows that this is a real threat in the community, especially for people who predominantly use stimulants. People also said it helps them build trust and rapport. You know, when you come to a client or participant with a harm reduction tool, it communicates like, I care about you. I care about whether or not you live or die. I know you're in my treatment program and technically you're not supposed to use drugs, but this is the real world. I know you might, and if you do, I want you to stay safe and come back and see me alive. So that's the type of rapport that harm reduction interactions can really bring into a clinical environment. The biggest barrier we heard was the staff's own lack of understanding of how these strips work. And that was fair. You know, it is really complicated. You need to do little scoops, a certain amount of water, ratio. There's a lot of instructions on the flyers we give out. And they're kind of hard to understand sometimes. So this is something this is feedback that we're taking in on our team and getting some much more intentional fentanyl test strip trainers and training so that we can get this out with more clarity. We also are very proud of the large and growing team of community consultants who do street outreach and training for us. So we now have almost 40 people across the state of Missouri who work on an hourly basis. All of them have their own lived experience with drug use and addiction in some form or fashion. And we know that they are better messengers than we are. And this might not be their full-time job, but they can do a few hours a week here or there. They can go do street outreach. They can go do a training, you know, at a local store in their town. And they can give out some of these flyers that we've developed. Shout out to Nico Ruiz on our team who conceptualized a lot of these one-pagers that we give out, going beyond opioid harm reduction, but talking about other drugs and how people can stay safe. So this team of consultants, this growing team, is really an extended workforce. And not only are they a workforce, but they are a source of rich information and partnership and relationship building. They tell us what is happening out there, and in exchange, we work with them to help supply them with what they need to keep their communities safe. Okay. Let's talk about what I highlighted at the beginning, which were these racial inequities in overdose deaths, especially among Black men. Missouri is not the only state that is seeing this trend around the country. This is what we're seeing in the third and fourth wave of the overdose crisis, is Black men getting hit harder, especially older Black men. If you look in St. Louis City and County, this top green line shows death rates among Black men in the city. They went down for the first time in almost forever last year, which is good, but still, 10 to 15 times higher than the national average. Then you look at deaths specifically involving stimulants and opioids, like we've talked about, and these top two yellow and green lines are Black men in the city and Black men in the county. So these are far and away higher rates than their peers, telling us that something else is going on. To address this, we partnered with multiple community organizations, Black-led community organizations doing work on racial equity and street outreach, and got funding from Missouri Foundation for Health to develop the Center Initiative, which focuses on advocacy, education, intervention, relationship building, and research. We're in the third year of this grant, and I want to highlight some of our research there, led by Dr. Devin Banks, who's with us today. The goal of our research on Center is to build on the what. We've talked about stats, we've talked about numbers, we know zip codes, we have maps, we know where people are dying and what they're dying of and who they are, but we don't necessarily know why. To get to the why, we can't rely on quantitative data and numbers alone. We need stories, we need interviews, we need focus groups. So the first study was our Black Advocates study, 2 focus groups with people who do street outreach and work directly with Black men who use drugs in St. Louis. I'm gonna highlight just a couple quick excerpts from some of the quotes we got. If you have no source of stability, no safety, nobody that you can go to when you're struggling, there's no safety for you. So now people are just trying to find ways, like you said, to cope and to deal with life. I think there's a lot of hopelessness. There's no place to go. I can get you on a waiting list. I'm not going to be alive when I'm 21, so I'm going to sell dope because at least I died with a little something more than what I had. Looking across these focus groups, we garnered some key themes and developed this model that we called the 4 S's. The idea being that what is driving overdose among Black men in St. Louis is a lack of 4 key needs. security, stability, safety, and survival. These manifest both in a lack of basic needs, like lack of housing and employment, and serious medical comorbidities, but also a lack of social support and structure needs in their neighborhoods and environment, positive relationships, history of significant trauma, domestic violence, bullet-related injury, police violence. All these things intermingle, combined with fentanyl in our drug supply to just make this a hotspot of death. Now, what we gather here is not just that a lack of the 4 S's leads to more overdose, but also if we invest in increasing these 4 S's, we can get out of this. This can be our ticket out of this population being so adversely affected. What our team is doing in our final year, we're trying to change the narrative, promote safer drug use, and increase service options in North St. Louis City and County, not just through the existing substance use system, but also through new Black-led systems by and for Black people who use drugs. So where do we go from here? What's on deck for our addiction science team specifically? We are excited to focus more on measurement. From a research standpoint, we've put in and been awarded some grants recently to look at how we know that what we're doing is working and how we're changing hearts and minds, specifically about knowledge and attitudes and perceptions about some of the more controversial strategies we've talked about today. We're excited about some projects that we're leading coming up. You can read this list if you want, doing more work with EMS to do buprenorphine in the field, doing more intentional work with recovery housing, building up the peer workforce, doing some public housing policy and change making, and much, much more. And we are really thrilled and grateful to be housed at UMSL, partnering both at MIMH and in the Psychological Sciences Department, building our substance use research group over in Psych, and doing more and more work with UMKC, their Addiction Technology and Transfer Center over there. We partner with on tons of our work at Mizzou, MoCare, and what's happening with the Psych Department and beyond. There's just a lot of promise to developing more collaboration and partnership across the UM system in the field of addiction science. So what do we know from our approach? We know that we've been bold and innovative here in Missouri. With the state's buy-in, we've been able to push the envelope a bit. We've developed and implemented MedFirst. We've helped establish harm reduction infrastructure in a state that policy-wise has not been friendly to it. In fact, SAMHSA has even recently taken on our medication first approach and promoted it as a best practice model, which is great and exciting and flattering. However, from our own data, we know that model will only take us so far. We know that it's helped expand access, but like we've talked about, we've plateaued, and we know some people are helped more than others. Through our MedFirst model, through our outreach, we've reached white people pretty effectively in Missouri and seen overdose rates go down. We cannot say the same for Black Missourians. If you look on Kaiser Family Foundation state rankings, most recently, we have the 4th highest overdose rate among Black people in the entire country, but the 27th highest rate for white people. So that should tell us something. What do we need in our communities? I'm not trying to say that we only need harm reduction or we only need medication. We need all of it. What we need is an ecosystem that's accessible in every neighborhood and every corner of this state. That includes everything people may want or need. So yes, residential treatment. Yes, recovery housing. Yes, medical treatment. Yes, peer support groups. Yes, transitional housing. Yes, syringe exchange. Yes, transportation, which is barrier number 1 for so many people trying to get access to care. And we need people navigating these systems with the people we're trying to help. Community health navigators, community health workers, peer specialists, literally and figuratively holding people's hands, getting them from one place to another, because this is where we lose people, in the gaps between these settings and these bifurcated systems. So what can you do today? You can do a lot, and you can do it from your computer for the most part. So join the conversation, follow us on Twitter and Facebook and Instagram. If you don't like the tech stuff, at least try to change the conversation around your family dinner table or when you go to Thanksgiving. Try to change people's perceptions of people who use drugs and what it takes to quote unquote get sober. You now know it's more complicated than that, and that we need our bold initiatives to try to keep pace with the changing nature of our volatile drug supply. You can get training through us, you can help us pack harm reduction kits, you can report an overdose through our system, and you can carry naloxone and save a life. I want to thank genuinely, like no jokes, from the bottom of my heart, our addiction science team. None of this work would have happened without every single person on this team. Substance use research group, our funders, and relational partners across the state. And I'll leave some time for questions.
Thank you so much, Dr. Winograd. I wanted to start out with the question that we got online really quickly about, you showed us some really great stats, or poor stats, but do you have any data on how many overdoses we have at Missouri colleges, or how much naloxone and test strip distributions we've done to students?
Those are great questions. I cannot answer the first one. I don't know about how many overdose events there have been at college campuses. I think, to my knowledge, it's fewer than average. Like, it's college campuses themselves are not a hotspot for drug overdose. They're a hotspot for alcohol poisoning, which is a whole other talk that I'm sure many of the Mizzou folks are very familiar with. In terms of how much naloxone and fentanyl test strips go out, we do partner with Partners in Prevention. And we could pull those numbers if someone was really interested, because we absolutely distribute through those networks. And I think it's a great group to target, even if we're not seeing a ton of overdoses. You never know who's going to take those back into their communities and save a life.
Thank you. And on the same thread, another one came in asking about what about trends in rural Missouri?
Trends in rural Missouri. So we, for the last 5-10 years, I mean, we have seen, in terms of deaths, they're clustered more in the urban areas still. Not to say that we're not seeing deaths in rural areas, and a death is a death and it is a death. And when you're talking about actual rates, not counts, the populations are lower in rural areas. So if you lose 3 people in a community, I mean, that's a huge impact, and that's devastating. So, their problems are different, but often end up kind of manifesting the same in terms of inability to access resources. So in metro areas, you might have like a ton of treatment centers, but waiting lists around the block, and it's really hard to get in. In rural areas, there might be treatment centers with room, but you got to drive an hour and a half each way. So that piece of lack of access to resources is a problem, like wherever you look.
Great, thank you. Any questions in this room? Oh, one second.
Yes, Dr. Spilling.
So what does overdose look like, and how long do you have to administer naloxone?
Great question. So an opioid overdose looks like someone is flat out. They're unresponsive on the floor or seated. You cannot wake them up. You can nudge them or try to give a little gentle slap, but they are unresponsive. If you look at their eyes, their pupils are pinpoints. Their skin is cold and clammy. Their breathing is really shallow. There might be a rattle. People refer to that as a death rattle. Their skin around their lips and fingernails might be turning gray or blue. And that's what an overdose looks like. So it's basically when your lungs stop talking to your brain and you almost stop breathing or get really shallow breathing. Was that your only question?
No, how long do you
Oh, how long do you have? Yes. So time is of the essence, and that is another reason why fentanyl is so scary. When we were seeing overdoses on prescription pills, you could have 30 minutes, an hour, hours to respond to an overdose while people were still barely breathing, but breathing. With fentanyl, it can happen in 1 to 2 minutes. The oxygen's cut off from the brain, and already you have hypoxia, and we're going into brain damage territory and then death. So you hear about people, accounts early when fentanyl was on the scene is people would inject it into the arm and then put their hand to the mouth like they were literally losing their breath. And then right then, it's, you have to get there in seconds to a minute. And that's another reason why community naloxone saturation is so important, because no matter where you are in Missouri, you could be waiting for 911 to respond. It could be 5 minutes, 10 minutes, 30 minutes, depending on where you are. So the real first responder is whoever is in a position to call 911. And that's why it's so important not to use drugs alone.
How long does naloxone last on the shelf? You have to redistribute.
I can repeat it. Yeah. How long does naloxone last? What's its shelf life? So there's a technical answer and there's a real answer. So the technical answer is that like Narcan nasal spray says it has a 2-year expiration. That being said, there have been FDA trials looking at it 5, 10 years past expiration. It's still fine. It's better to use it. What we do for our distribution to law enforcement and EMS and other entities that like regulatory wise cannot have expired product, we collect it back, give them a recent supply, and we give the expired product to community harm reduction groups that are like, yeah, fine, we'll take it. We just need it. So we do not ever throw naloxone in the trash can. There is no need for that. We can collect it and give it back out. But the only thing that would hamper its shelf life is if it's really exposed to the elements, if you keep it outside in freezing or over 100-degree weather.
I wanted to mention, there was a question about, you talked about some of the challenges when training. In your presentation, I saw about sometimes the training on how to use the fentanyl strips being a challenge. But there was a question about any additional challenges you find when you're trying to accomplish on-the-ground programming.
Oh my goodness. Of course. I mean, that's all we deal with. How much time do we have, Mary? Yeah, no, it's incredibly challenging.
They mentioned the labor challenges you talked about. Right?
Sure. I mean, we have challenges with our community programming everywhere you turn. I'm sure I've missed a lot on our Teams chat just in the last hour of some new challenges that have emerged. It could be everything from receptivity and people like not being open to wanting our content and what we have to say. It can be logistics wise, like people just want to do training in person, and we have to decide like, okay, how much staff do we have? How many partners do we have? It can be challenges in terms of that's not my problem, or this is my boss's problem, or this is my staff's problem, or this is the hospital's problem, or this is the Department of Corrections problems. So I could do another talk if you'll have me back in a few years about partnerships and challenges and what we learned from our community work. But that being said, it's the most real and rewarding work that I've ever been a part of, and I wouldn't have it any other way.
I received an email actually before this talk started from a mom who mentioned that she lost her son to an overdose, and she wanted to ask about what types of work there was being done for prevention on mental health side. That she talked about her son getting addicted at the age of 14.
Yeah, no, the youth prevention aspect is really tricky as well, because we can have programming in schools, but we don't really know how effective that is for a given kiddo. We can have community programming and awareness. There are some fantastic prevention resource centers across the state who are really the hub in each region for youth programming. And it looks different, but I think there's a lot of agreement now that we need to think beyond school-based drug awareness programming and go much more into community, talk about adverse childhood events, talk about food insecurity. What about free after-school programs? What about free lunch programs? What about adult mentors? Like, how do we think about drug prevention? And it's really about like holistic and supportive youth development.
Thank you. And I think that there's audio from Next Gen.
We have a question. What is the source from the dashboard you showed of the non-fatal overdoses?
Yes.
Your source?
So that is our overdose field report, which is the results are now housed on our ENACT website. So enact.mo.org. I'm looking at Kyle. Yes. We're in the process of revamping that overdose field report as well, and looking at how they've done some things in Texas similarly and trying to modernize that a bit.
Well, with our wrapping up, thank you so much for presenting your critically important work and beautiful talk. And I seems like it worked pretty well, having two sites, so thank you so much, and
Okay.
thanks for everybody joining and your attention. Great questions.